Welcome to study session 12. Introduction. Injuries to the spinal cord affect people of all ages but take their greatest toll on young people. You will therefore examine problems of spinal cord and how to manage them in this study session. Note that these injuries are characterized by decrease or loss of sensory and motor function below the level of the injury. Learning outcomes. When you have studied this session, you should be able to 1. Manage spinal cord injury. 2. Manage spinal cord tumors. Spinal cord injury. Pathophysiology. The spinal cord is made up of nerve fibers that allow communication between the brain and the rest of the body. Damage to the spinal cord results in interference with this communication process. Damage may be caused by bruising, tearing, cutting, edema, or bleeding into the cord. The damage may be caused by external forces or by fragments of fractured bones. Causes of spinal cord injury. Spinal cord injury (SCI) happens for a wide variety of reasons. Injuries due to trauma are the most common. Damage to the spinal cord can occur due to many reasons other than trauma. These include infection, stroke, tumor, inflammation, and several congenital causes. Each of these causes will produce a differing pattern of nerve damage, resulting in differing patterns of sensory loss and paralysis. Injury types and classification. Spinal cord injuries may be classified by location or by degree of damage to the cord. In order to allow health workers to communicate accurately about their patients, a system has been developed to describe a spinal cord injury. Typically, nurses and doctors will name the lowest level of the spinal cord with normal neurological function. This is called the level of the lesion. For example, if Joe has good biceps muscle strength, a cybercaf 5 or C5 muscle, but poor wrist extension, a C6 muscle. Paraplegia refers to a spinal injury below the T1 spinal level. Typically, these injuries result in some degree of weakness and sensory changes in the trunk, legs, and feet. Individuals with paraplegia have injury to their spinal cord from thoracic 2 or T2 or on down through sacral 5 S5. Tetraplegia refers to a spinal cord injury at or above the T1 spinal level. Typically, tetraplegia results in weakness or sensory changes of arms or hands and legs. In the past, doctors referred to this sort of injury as quadriplegia. Tetraplegia is now the preferred term in the medical community, although quadriplegia is still commonly used. Degree of injury: incomplete versus complete. The technical definition of an incomplete injury is quite complex and relates to whether someone has sensation around their anus and or the ability to contract their anal sphincter at will and or if they have deep sensation inside the rectum, e.g. you know when an enema is inserted that your bowels are moving, etc. This is due to the fact that some nerve signals pass across the damaged segment of the spinal cord. Complete lesion is when there is no movement and no sensation below their injury level, and in particular, have no sensation or movement in the anal area. The classification for someone with a complete injury is AISA. AIS stands for Asia Impairment Scale. Asia stands for the American Spinal Injury Association. This is the internationally accepted scale. An incomplete spinal cord injury is classified as an AIS, B, C, D, or E. B. Sensory sparing may only be around the anus at first. C. 50% of the muscles below the injury level are not working at anti-gravity. That is, they are not strong enough for you to use them in a functional way. D. 50% of the muscles below the injury level are working at anti-gravity. E. Normal muscle strength in all muscle groups, and a person with this degree of injury probably won't need to be an inpatient in the spinal unit at all but may have some bladder. Pattern of injury. If we look within the spinal cord, we find that it has a very specific organization. Sensory nerves travel with other sensory nerves, motor nerves likewise. Additionally, the nerves to particular body parts also travel bundled together in specific parts of the spinal cord. This means that some injuries to the spinal cord lead to injuries to specific nerve parts, producing characteristic patterns of weakness and numbness. There are two common patterns of SCI, which are central cord syndrome. The central cord syndrome results from an injury to the central part of the spinal cord in the cervical neck region, leading to tetraplegia. As the nerves which supply the arms lie more centrally in the cord, the arms tend to be more affected than other areas of the body. Caudal equina syndrome. The spinal cord actually ends at the L2 vertebral level. However, the nerve roots continue past this level and resemble a horse's tail, or cauda equina in Latin. Injury to this area may cause weakness and or loss of sensation in the lower limbs, e.g. at the hips, knees, ankles, and or the back of the legs and buttocks, as well as bowel, bladder, and sexual dysfunction. Signs and symptoms. Cervical injuries. Cervical cord injuries can affect all four extremities, causing paralysis and paresthesias, impaired respiration, and loss of bowel and bladder control. Paralysis of all four extremities is called quadriplegia. Weakness of all extremities is called quadriparesis. If the injury is at C3 or above, the injury is usually fatal because muscles used for breathing are paralyzed. An injury at the fourth or fifth cervical vertebrae affects breathing and may necessitate some type of ventilator support. Thoracic and lumbar injuries. Thoracic and lumbar injuries affect the legs, bowel, and bladder. Paralysis of the legs is called paraplegia. Weakness of the leg is called paresis. Sacral injuries affect bowel and bladder continence and may affect foot function. Individuals with thoracic, lumbar, and sacral injuries can usually learn to perform activities of daily living independently. Spinal shock. Spinal cord injury has a profound effect on the autonomic nervous system. Immediately following injury, the cord below the injury stops functioning completely. This causes a disruption of the sympathetic nervous system, resulting in vasodilation, hypotension, and bradycardia, neurogenic shock or spinal shock. Dilation of the blood vessels allows more blood flow just beneath the skin. This blood cools and is circulated throughout the body, causing hypothermia. The patient is unable to maintain control of body temperature. Complications of spinal cord injury. Infection. Impaired respiratory effort, decreased cough, mechanical ventilation, and immobility all predispose the cervical cord injured patient to pneumonia. Catheterization, whether dwelling or intermittent places, patients at risk for urinary tract infection. Deep vein thrombosis, lack of movement in the legs inhibits normal blood circulation. Orthostatic hypotension. Most spinal cord injured patients no longer have muscular function in their legs to promote venous return to the heart. They also have impaired vasoconstriction. This leads to pooling of the blood in the legs when the patient moves from a supine to a sitting position. If the movement is sudden, the patient may faint. Skin breakdown. Patients or their caregivers must be diligent about relieving pressure on the skin by position changes and cushioning of bony prominences. Renal complications. Urinary tract infections are an ongoing concern to spinal cord injured patients. Both urinary reflux and untreated urinary tract infections can cause permanent damage to the kidneys. Depression and substance abuse. Patients with spinal cord injury have a higher than average incidence of depression and substance abuse. Both these factors can interfere with the patient's ability to care for himself or herself. Autonomic dysreflexia. This life-threatening complication occurs in patients with injuries above the T6 level. The spinal cord injury impairs the normal equilibrium between the sympathetic and parasympathetic autonomic nervous system. Some type of noxious stimuli below the spinal cord injury causes activation of the sympathetic system. This response continues unchecked because the parasympathetic responses cannot descend past the spinal cord injury. The most common cause of autonomic dysreflexia is bladder distension. Other causes include bowel impaction, urinary tract infection, ingrown toenails, pressure ulcers, pain, and labor. Stimulation of the sympathetic nervous system results in cool, pale skin, goose flesh, and vasoconstriction below the level of the injury. Blood pressure may rise as high as 300 mmHg systolic. The parasympathetic response results in vasodilation, causing flushing and diaphoresis above the lesion, and bradycardia as low as 30 beats per minute. The patient complains of a pounding headache and nasal congestion secondary to the dilated blood vessels. Diagnostic tests: 1. Plain radiographs are done to identify fractures or displacements of vertebrae. 2. CT scan is also useful for identifying fractures. 3. MRI may demonstrate lesions within the cord. Treatment: patients with spinal cord injuries typically are brought to the emergency department. They should be kept immobilized until they are assessed by the physician. If injury to the spinal cord is detected, the patient needs to remain immobilized. Emergency medical management. Emergency management involves careful monitoring of vital signs and airway and keeping the patient immobilized. Intubation and mechanical ventilation may be necessary. Intravenous normal saline may be used for fluid replacement. Vasoactive drugs may be required. Various medications to reduce the extent of injury, including intravenous methylprednisolone, a steroid, are currently being researched. Respiratory management. Patients with injuries above C4 to 5 have some degree of respiratory impairment. The patient may require a tracheostomy and continuous mechanical ventilation, or require a ventilator only at night or when fatigued. However, if the diaphragm is paralyzed, the intercostal muscles become very important. As these muscles fatigue, the patient's breathing becomes shallow and rapid. Elective intubation and mechanical ventilation protect the patient from expending huge amounts of energy trying to breathe. Gastrointestinal management. Absence of bowel sounds is a common finding on examination. Oral or enteral feedings are not started until bowel function resumes. The metabolic needs of the patients are influenced by the work of breathing and the extent of other injuries. Genitourinary management. An indwelling urinary catheter is placed to prevent bladder distension. Immobilization. The cervical spine may be immobilized with skeletal traction, such as Crutchfield or Gardner-Wells tongues. Some patients have a hollow brace, a device that attaches to the skull with 4 small pins. The skull ring attaches to a rigid plastic vest by 4 poles. This device keeps the head and neck immobile while fusion and healing take place. Surgical management. Surgery is indicated in any of the following instances. 1. Compression of the cord is evident. 2. The injury results in a fragmented or unstable vertebral body. 3. The injury involves a wound that penetrates the cord. 4. There are bony fragments in the spinal canal. 5. The patient's neurologic status is deteriorating. Surgery is performed to reduce the spinal fracture or dislocation or to decompress the cord. A laminectomy, excision of the posterior arcs and spinous processes of a vertebra, may be indicated in the presence of progressive neurologic deficit, suspected epidural hematoma, bony fragments, or penetrating injuries that require surgical debridement, or to permit direct visualization and exploration of the cord. Vertebral bodies may also be surgically fused to create a stable spinal column. Patient education. Education of the spinal cord injured patient is an ongoing process. It begins with a basic explanation of the anatomy and physiology of the spine. Treatment of spinal cord injury and prognosis are early learning needs. As the patient's condition stabilizes, teaching focuses on caring for the patient. This can seem overwhelming to the patient and caregiver. The nurse should 1. Break tasks down into simple steps. 2. Focus on one body system at a time. For example, do not try to teach suctioning and bowel care at the same time. 3. Begin with the basics. Extensive teaching will be done in the rehabilitation setting. 3. Begin with the basics. Extensive teaching will be done in the rehabilitation setting. 4. Be aware that performing tasks such as catheterization or bowel care, may interfere with feelings of intimacy between partners. Encourage partners to verbalize these feelings and make alternative arrangements for care if possible. Some patients with financial resources to do so may choose to hire an attendant rather than rely on significant others for personal care. Functional abilities after spinal cord injury. Functional abilities vary according to the level and nature of spinal cord injury. Spinal cord tumors. Tumors within the spine are classified according to their anatomic relation to the spinal cord. They include intramedullary lesions within the spinal cord, extramedullary intramedullary lesions within or under the spinal dura, and extramedullary extradural lesions outside the dural membrane. Tumors occurring within the spinal cord or exerting pressure on it cause symptoms ranging from localized or shooting pains and weakness and loss of reflexes above the tumor level to progressive loss of motor function and paralysis. Usually, sharp pain occurs in the area innervated by the spinal roots that arise from the cord in the region of the tumor. In addition, increasing sensory deficits develop below the level of the lesion. Assessment and diagnostic findings. Neurologic examination and diagnostic studies are used to make the diagnosis. Neurologic examination includes assessment of pain, loss of reflexes, loss of sensation or motor function, and the presence of weaknesses and paralysis. Helpful diagnostic studies include X-rays, radionuclide bone scans, and MRI. 2. MRI is the most sensitive diagnostic tool and is particularly helpful in detecting epidural spinal cord compression and vertebral bone. Medical management. Treatment of specific intraspinal tumors depends on the type and location of the tumor and the presenting symptoms and physical status of the patient. Surgical intervention is the primary treatment for most spinal cord tumors. Other treatment modalities include partial removal of the tumor, the compression of the spinal cord, chemotherapy, and radiation therapy, particularly for intramedullary tumors and metastatic lesions. In the patient with epidural spinal cord compression resulting from metastatic cancer, most commonly from breast, prostate, or lung, high-dose dexamethasone combined with radiation therapy is effective in relieving pain. Surgical management. Tumor removal is desirable but not always possible. The goal is to remove as much tumor as possible while sparing uninvolved portions of the spinal cord. Microsurgical techniques have improved the prognosis for patients with intramedullary tumors. Prognosis is related to the degree of neurologic impairment at the time of surgery, the speed with which symptoms occurred, and the tumor origin. Patients with extensive neurologic deficits before surgery usually do not make significant functional recovery even after successful tumor removal. Study session summary. In this study session, you learned how to manage spinal cord injury and spinal cord tumors. We have come to the end of study session 12.